This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app.
Hi everybody, Rob Watkins here again. Doing a Facebook Live. It's been a while since I've actually done a Facebook Live. I think I kind of took the holiday season off. And I just want to one thing I want to just recognize is I appreciate everybody's support about the community council in Mar Vista that I was elected to last night, and I look forward to trying to help out our community in any way I can, and greater Los Angeles, solve all the issues going on. Also, my time gets taken up with I'm chief of staff of the Cedars-Sinai Marina Del Rey Hospital. That just started this month, so it's a 2-year appointment, and I'm going to help work on the quality and the safety and the efficiency of the hospital, which has been a great place to work. And so I appreciate everybody's support in doing that and people trusting me with helping to make some of these decisions. But what I wanted to talk about tonight, which is what I've been meaning to talk about for the past couple months, is spine surgery and minimally invasive spine surgery, what it is. What does that mean? You might, if you have any back problems or neck problems, you may Google it and see all this talk about minimally invasive surgery. You hear about it in any type of surgery, and so I'm going to give you an idea as to what that means. And because despite doing other extracurricular hobbies, 90% of my day is doing spine surgery and meeting with people and trying to figure out what's best for them. And then ultimately, if it comes to having surgery, and non-surgery we always do first. We have our Back Doctor app, which has a whole rehab program on it, trying to avoid surgery. We do epidurals, we do acupuncture. My wife, Michelle, does hypnosis and meditation and Reiki. So you can try a million different things, but ultimately if it comes to surgery, if you need it, what does minimally invasive mean is basically what's the least invasive, safest surgery you can do that causes the least destruction to the muscles and the bone and the stabilizing structure. How can you get in there, do this small surgery, treat the problem, and get out and don't cause more of a problem than what it takes to do it? And so a lot of minimally invasive surgery has been around probably 15, 20 years in its real heyday. Some of it's just marketing, and it's tough to sort out. People may tell you they're going to do something minimally invasive, but what does that mean? Is it truly minimally invasive? And also, but more importantly, is it still safe? Because, in the spine, we have nerves that we're working around. And it's okay if you make a tiny incision and sneak in there and don't cause a lot of destruction, but can you see what you're doing? Can you safely retract the nerve and take out the pathology to where everything you see you can do? And one of the things in our practice, I work with my dad and Dave Chang, who's great. We work together. We have 2 spine surgeons on almost every case, and the ability to do the surgery safely is the key for us automatically. You got to get a good result, do it safely. Then number 2 is what's the least invasive approach we can do to save as much as possible. So I'll tell you a bit about my experience in this realm and what I've learned and what I think the future is. So my experience, I've been in practice 16, I think it's maybe my 17th year. And when I first joined my father in practice, I spent a couple weeks with Kevin Foley and Rick Fessler, who are some of the original pioneers of minimally invasive spine surgery. And that mainly meant using tubular retractors. So there's 2 main issues we'll talk about. One is, what's the retractor you use? How are you going to pull the muscles out of the way and keep them out of the way to do the surgery? What's the retractor? Number 2 is, how are you going to visualize it? And when it comes to visualization, there's 4 basic options. Just use your eyes. Number 2 is use microscopic loops that are like magnifying loops that you wear on your head. Those glasses, you've seen them in TV shows, big glasses. Number 3 is a microscope. And the real benefit of the microscope, that's the main thing we use, is your assistant can see what you see. So you're not banging heads in the surgery. You can see the same thing. And like I said, we have 2 spine surgeons on almost every surgery. So our assistant can help retract the nerve or take out disc. You basically get 3 or 4 hands in there doing work rather than just 2, and it can be a real benefit. And then the 4th type of visualization is an endoscope, and that's something I'll talk about part of more of the future. The endoscopic technology has gotten better and better, where you can use just like an arthroscope in a knee, where you're using the camera is attached to the portal, and you look up at a TV screen and see everything on a TV screen. And so that's the visualization. And then as far as the retractor goes, there's 2 basic retractors that we use. It's either going to be a tubular retractor or more of a blade and spike retractor. And we use both. And there's pluses and minuses to both. So the tubular retractor, the idea is, Cardocchi says the future is now. I love it. I'll bring you up, Ray. You're coming up. So the tubular retractor, the idea basically is typically use a fluoro machine, use an x-ray to show you where you're going to go. You put a marker needle into where you want to go, and then you make a small incision, and then over a small needle or a small tubular retractor, even smaller than a pin, you dilate over that tube. So you use 2, 3, 4 larger tubes to dilate over it to make a hole in the muscle. The tube basically sits right down on the spine, and then through the tube, you look through the tube, and either with a microscope or an endoscope, whatever visualization, you look through the tube and you do the whole surgery through the tube. And then the cool part about at the end of the surgery is you take the tube out and the hole in the muscle closes back down. And I've got some great videos of doing that where you see everything close down, and it can work really well. The blade and spike retractor is the other alternative, also called a McCullough retractor, which basically pulls the muscle back with the blade. A spike sits in between the bone, holds the muscle back. You do the surgery. At the end of the surgery, you sew the fascia back. The muscle closes back down. So in my experience, basically, my first 2 years of practice, we used a tubular retractor on every discectomy we did, taking out disc herniations. We used it on every, we thought it was the real future, that the future is now. We used a tubular retractor on every discectomy we did. And what we found was that the classic 90-95% of disc herniations that are in the canal, which are central in the canal, the tubular retractor really didn't help us much. As far as the size of the incision, the muscle dissection, whatever took place, it was about the same as a blade and spike retractor. We didn't really feel like it had much advantage. And one of the limitations was, one was taking x-ray and setting everything up took longer. Number two is that the tube sometimes could limit the angle that you got to certain areas. If you use a blade and spike and you can't quite get to what you need to get to, well, you can just extend it, and it's not that big of a deal. For about 5 to 10% of herniations that happen out here on the side in the foramen, we have found the tubular retractor is brilliant. And the reason why that's different is because we actually come in at like a 30-degree angle, where I'll take an x-ray at a 30-degree angle, mark the skin, and now I'm coming through all this muscle. And holding that muscle out of the way is very difficult with a blade and spike retractor. Everything creeps in. You can't see what you're doing. You have to burn more muscle to see what you're doing. The tubular retractor allows us to take an x-ray, take a fluoro, put that tube right into the hole, the foramen. And I do epidural injections, so it's the same approach I do for an epidural, a transforaminal epidural. You just put your needle down, dilate up, use that tube in there. And then I use a microscope. And then when we finish the surgery, we take the tube out and the hole in the muscle closes back down. So, one of the real benefits and one of the greatest approaches to spine surgery and medicine in general is learn different techniques, figure out what makes the most sense for each unique pathology, and use that. And it doesn't mean you have to use a tube for every surgery, but if it makes sense, use the tube. If it doesn't, if it's going to limit you, well, then you don't need it. And it may take you longer, and it may limit your retraction, your ability to do the surgery safely. And I'm going to mention one other thing about the cervical spine up in the necks. The tubular retractor we found up in the necks, to get the angle you want to save the facet joint, you're bumping into the spinous process, and it could result in removing more of the joint. Well, if you have to remove more of the joint to get to the pathology, well, it's not as good because you're decreasing the stability. And that's an example of, yeah, you're using this tube, you're calling it minimally invasive, but if you're removing the stabilizing structure, you're causing more damage. That's not minimally invasive. And I'm not saying you can't use a tube in the neck and not make it and not take too much joint. But the blade and spike retractor, we found we were able to work from the opposite side of the table and undercut the joint and save more of the joint, and the tube just got in the way and blocked our ability to do that, and it wasn't saving that much muscle function to be worthwhile. So what it comes down to is when we're doing spine surgery, we have to treat the nerves. That's the number one thing, is safely retract the nerve, take the pressure off the nerve, see what you're doing, be able to use the proper instruments to do that. And then cause as little destruction of the muscles and the surrounding structures as possible. And mixing and matching the way to do that is the safest way to go. Another component of that is using the microscope with the blade and spike retractor. Is we've done that surgery on almost 100 professional athletes in just about every sport. We published results in I think 65 or 70 of them, and our return to sports is 89%. And the average return is 3 to 6 months. It's not 100%, but 89% is about as good as it gets in our business. And so that's a pretty good surgery is the point. We're able to take the pressure off the nerve through a minimally invasive approach enough to get them back to play sports. So going away from that to be less invasive with smaller incisions, well, you're going to be able to do the surgery as safely and as effectively, so is it worth it? And that's the fundamental question. And so I'm glad Ray's watching because Ray Gardocki trained with my dad, and we were residents together at USC. He was a year above me, and I just did a lab with Ray. And one of the cool technologies that's coming out that I'm excited about is the endoscope with navigation. And because part of the issue with the endoscope is, can you see where you are? Can you see where's the bone, where's the fat, where's the nerve, where's the ligament to safely do the surgery? And ultimately, if you can do it as safe and you are less invasive, well, then it's a better technique. But in order to do it as safely, you got to know where you are. And if that means you got to shoot x-rays throughout the case and take x-ray after x-ray, so the patient's getting more radiation, the whole staff is, the doctor has to wear lead, then it may not be worth it. But if you combine it with navigation, which basically means you can take an x-ray, AP and a lateral x-ray, and then use navigation to show where you are and see on an x-ray the bone and the disc, where you know where the nerve is going to be, look at your endoscopic screen and see those structures and merge them together, well, that's the combination of both worlds. And one of the reasons why I'm very fired up about that is, and see the potential, is that I use computer navigation right now. In fact, we have for 15 years. Every screw we've put in, we've used a three-dimensional computer navigation for 15 years, and I've been sold on that forever. That's the greatest advance in our business, I think. So to be able to merge these two technologies together, I'm really excited about it because, quite frankly, I don't know right now if doing the surgery through an endoscope will make a difference in the clinical outcomes, because right now our clinical outcomes are so good with the way we do it. But if the muscle dissection and the fascial dissection is less, well, that's better. And maybe we can't even prove it in outcomes because the results are so good it can be tough to prove a difference. But if you know you can do the surgery as safely and as effectively, and you know your approach is less invasive, then it's worth doing. And that's a theoretic benefit. So my plan going forward is to research the endoscopic computer-guided surgery with navigation and see if it makes sense and see if I really think it's a benefit. And so one of the projects I'm taking on over the next several months is and how do we research this? We do it in cadaver labs. We go and visit other doctors. We have them come visit us. And one of the great things I've experienced about the medical community is the openness with which doctors share with each other. I've visited many doctors throughout my career to see what they do. I've had hundreds of doctors come to visit me and see what we do. And so we're coming to Memphis, Ray. We're coming to check out what you do. Plus, we can go get some real fried chicken while we're in Memphis. And Paul Hull, as well, is a great endoscopic surgeon that I enjoyed meeting. So I'm going to come visit you too, Paul. And so ultimately, minimally invasive spine surgery, you got to strip away what the hype is and what the marketing is and really get down to what makes sense. Are you doing things as safe? Are you doing it as effectively? Are you able to do it, and then are you able to do it through a small incision with the least soft tissue destruction as possible? Then it's a good, sound, safe approach. And so I'll keep you guys updated on the whole process. And if you guys have any fresh questions, please feel free to chime in. Thanks, guys. Have a good night. Bye.